Have we got Dr. Start?
Sir, Vinod Paul has joined.
Okay, then we can go back to the order then. We'll go back to the order and Dr. Nandkumar will start with Dr. Vinod Paul. And please tell us when you're ready to start. So we're waiting for a cue from AAPI to start. Dr. Tandon, tell us when you want us to start.
So Dr. Sareen might take some time, so you can go ahead.
That's fine. That's all right. So we'll see. If he joins by the time Dr. Paul finishes, let us know. Otherwise, we'll go with Dr. Guleria and then with Dr. Ganguly. But please give us a cue on when you want us to start, please, from AAPI. We're just waiting for AAPI to give us the go-ahead to start. So just bear with us for a couple of minutes.
Dr. Saibal, this Vijaya, are you waiting for some AAPI leadership?
We are ready. Whenever you give us the go-ahead, Vijaya, we're ready.
Yeah, go ahead, Dr. Saibal. Yeah.
Namaste. It's 5 a.m. in LA and Vancouver. It's 8 a.m. in New York. Good morning to our colleagues in the United States and Canada. It's 1 p.m. in London, 2 p.m. in Europe. So good afternoon to our colleagues in Europe. It's 5:30 p.m. in India, 8 p.m. in Singapore. Good evening to all our colleagues in Asia. And it's 10 p.m. well past bedtime for our colleagues in Australia. Namaste. A warm welcome to all our colleagues. I'd like to start by thanking Dr. Suresh Reddy, the president of AAPI and the AAPI team for this invitation to be a part of the AAPI Virtual Summit. I'm Anupam Sibal. I'm the president of GAPIO and I work as a pediatric gastroenterologist and the group medical director of Apollo Hospitals. For those who are joining us for the first time, the Global Indian Physicians COVID-19 Collaborative was established on 11th April to bring together 1.4 million physicians of Indian origin across the globe on one platform. GAPIO now has members from 45 countries. It's day 180 since the first case of COVID-19 was diagnosed. COVID-19 has now been reported from more than 200 countries and territories. And as we speak, the 10 million cases mark has been crossed and sadly, more than 500,000 individuals have died. In India, we've crossed 528,000 cases with slightly over 16,000 deaths. There's been an explosion of knowledge like we've never seen before. Till date, 26,855 papers have been published on PubMed, 149 per day, which is really 10, which is every 10 minutes a paper is published. And we've had a sizable number of publications from India, 1,289. Today, we'll be discussing COVID-19 in India, and we really have a very distinguished panel of experts from India and distinguished moderators from across the globe. So let's get started. It's a privilege for me to introduce Dr. Nandkumar Jairam. Dr. Nand Kumar Jairam is the CEO, Chairman and Group Medical Director of Columbia Asia Hospitals. He's a distinguished surgeon, was the head of surgery at St. John's. He's been a chairman of NABH and chairman on the FICCI Committee on Health, and he is currently the vice president of GAPIO. Over to you, Dr. Nand Kumar.
Thank you, Anupam. As we have very little time, I'll get down to what we have to do, and that is to introduce Dr. Professor Vinod Paul. And it's a pleasure and privilege for me to do that. Who doesn't know Dr. Paul? Dr. Vinod Paul, the member of Niti Aayog, Government of India, an eminent neonatologist, academician, and researcher, closely associated with India's health policy, and has played various roles over the last 3 decades of eminence. He has been pivotal in formulating the Poshan Abhiyan and the Ayushman Bharat initiative of the Government of India, and is the chairman of the Board of Governors of the Medical Council of India. He was head of the Department of Pediatrics at AIIMS before starting his tenure at Niti Aayog. We are privileged to have him in our midst. And over to you, sir, for your presentation of 10 minutes. Dr. Paul.
Thank you very much, colleagues from all over the world. It's a pleasure to connect with you, although it is difficult times for all of us across the globe, and health professionals in particular are stressed, are being called upon to play a much deeper, much bigger, much riskier job, but we are together in this battle. India, being a country of more than 1.3 billion population, is special to the extent and to the adverse outcomes of this pandemic. But so far, we believe India has done relatively well, although parts of India continue to be again, perhaps in the early stage of evolution of the epidemic within the country. Just to start with some numbers, you know that we are just over 500,000 cases as of now. Our first case was reported around 30th of January, and we have moved to a stage where we are about 500,000. Likewise, it's important to point out that our deaths are around 15,000 odd, under 16,000 even today. And we do state the fact that we are experiencing relatively lower mortality, around 3% overall. Case fatality rate of about 3%, which we believe is relatively better. It may have something to do with the young population that we're experiencing or other causes. We can go into that. There are other eminent experts. We can throw light on it. So 500,000 cases so far and about 15.5 thousand deaths so far. What's very important for us to note is that when we compare to the status of pandemic in the rest of the world, our situation today is relatively reassuring. Globally, per million, as of today, the cases are 1,297. So 1,300 per million is the average presence of this pandemic across the globe for every 1 million population, every 10 lakh population. We compare with that, we are at 385. So 385 per million cases vis-a-vis 1,300 per million global average. And just to put the context right, for USA, this is 7,846. So we are at 385, US 7,846. When we look at deaths, then global average of deaths per million is 64. India is 12, and the US is 387. So clearly, despite a huge size of this great nation, despite the fact that we have high population density, thus far, India has done very well. a death of 12 per million, and cases to the tune of 385 per million, contrasting with 1,300, and deaths-wise 64 is phenomenally low. Yes, we do believe that there is, we don't know what the future will hold. What we also know today is that the disease is localized in parts of India. It is not a general pandemic all over in the same way. As you would expect in an infectious disease of this nature, this disease loves people, more the density, more predilection we have for the pandemic to intensify and to affect people. So as of today, 85% of our active cases are in only 8 states. And we have 30 states and 5 union territories. So it is localized. 86% of the problem is in only 8 states. And equally importantly, 51 cities or districts account for 80% of the cases, and thereby more or less also the deaths. These 8 states do include, of course, Maharashtra, Delhi, Gujarat, West Bengal, UP, and of course, Tamil Nadu. So the geographies are limited even today, well into the pandemic globally. It is cities that are more involved, dense areas are more involved. And if you see the map ever, you'll see that it is localized on the western half of India largely. And this is the place where the travelers came in from outside the nation, and the initial spread that occurred through, external, foreign travel people coming into the country started. And these are in any case the large urban megapolis hubs where the flights landed and so on. So we believe that for this part of India, for these states, we are experiencing perhaps the most intense phase. We have huge battle in Maharashtra, but more specifically also in Mumbai, where the situation is now stabilizing. We have Chennai somewhat in a tough situation. It was doing well. Then we had some setbacks, and part of Chennai, or much of Chennai, is under lockdown for second time, or this time around again, for the same reason. Delhi, of course, is experiencing a relatively high escalating surge for the last few weeks. It again, despite our increased testing, has now stabilized around 3,000 cases a day, just about over 3,000 cases a day. The situation is being watched very carefully. In the last 2 weeks, very significant additional measures have been taken by the union government, by the direct intervention of the Prime Minister and the Home Minister. And there are efforts for disease control in Delhi. I'll come back to Delhi if need be in a little more detail. Also for augmenting the capacities to look after the patients, being done on a frenetic speed. So Delhi is responding. Delhi is now our battleground, in addition to, I would say, Mumbai and Chennai in particular. However, much of India's heartland is relatively spared. We had expected seeding of the infection as a result of our migrant brothers and sisters moving back to their homes post-lockdown, but that hopefully has not been that kind of a nightmare as one would have expected and feared. I think these were young people relatively. They were asymptomatic. They didn't have huge viral loads. And when they were contained outside their villages by the village communities, very effective way, respectfully, in a very effective way, the disease spread in the rural area as a result of that situation did not go that far. Although very carefully, we are watching the heartland of India, Uttar Pradesh, Bihar, Orissa, West Bengal, and we cannot take, of course, for granted that the situation would remain relatively stable there. All the time, there is a likelihood of a spillover from peri-urban areas into rural areas. And that poses different challenges. But let me also say that because the population densities in rural areas are relatively better, low, and therefore it is not expected to explode as much as it would in dense populations. At the same time, if we are vigilant to control, to institute containment measures is not very difficult in rural areas because it's all spread out, and we can use the approach of containment strategies, the well-known approach of tracing, testing, isolation, and quarantine to mount an effective response. I would like to mention as a second part the very important decision that the government took at a stage when we did not have a relatively high number of cases. We only had 500 odd. But a very important decision was taken to shut down the entire country. And this was done because we could see that we were entering the exponential phase, early though, but we were entering the exponential phase of the pandemic. And the choice was we allow this to go and then take measures later on, or to now take severe measures to break the chain of transmission, suppress it effectively, and use the time for preparing for the next phase, namely in terms of your surveillance, your testing strategy, in terms of the beds and the hospitals and administrative preparedness and so on. We took this decision as a nation. All chief ministers supported the prime minister. It was supported by the academia. It was supported by WHO. It was supported by academics across the world, including very eminent people in the US. As a result of the lockdown, the first two phases, which is 3 weeks plus 3 weeks, about 6 weeks, going up to 15th of May, from 25th of March to 15th of May. We believe on scientific analysis that we could reduce or avert between 1.4 to 2.9 million infections as confirmed cases done by the strategy that we employ. There is a bubble of the unknown asymptomatic. We're not talking about that. So we averted, we believe, anything between 1.4 to 2.9 million infections, and we averted anything between 38,000 to 79,000 deaths during that period. But it also gave us time to ramp up our capacities, and we're very proud of that. On that day when the lockdown was instituted, we had less than 50 laboratories for testing in the country. At the end of this phase of lockdown, we had more than 500, and today we have more than 1,000 laboratories and a capacity to do the largest number of RT-PCR tests in a day, perhaps in the world. We are now testing something like 2.2 lakh to 20,000 tests every day, and we have crossed the 1 crore mark of the tests. So we ramped up that capacity. We mobilized nationally more than 3.2 lakh isolation, ICU, and hospital isolation beds, ICU beds, and ventilator beds. These are hospital beds, 3.25 lakh hospital beds. In addition, we mobilized observation beds to the tune of 6.45 lakh, double this number nationally in all districts. And here I'm proud to say that the partnership of the public sector and the private sector came up immensely as one nation, one system, and one huge mega response to this pandemic. We got full support from the private sector, and we continue to have that support. Private sector has been our very shining example of the high quality healthcare, and their presence in critical care is very well known, and we are very proud. And so through this partnership and the public sector engagement, it was possible to mount a huge preparation. Now remember, if lockdown hasn't been done or done late, as happened in many developed countries, then this time was never there for us. And perhaps the numbers that I quoted in terms of the low level of the overall pandemic, the tune of 12 per million vis-a-vis, 12 per million deaths vis-a-vis, many times deaths that I mentioned at the outset of my start of my talk would not have happened. So we continue to be very vigilant. We are now in a phase where we have opened up. Most activities are now allowed. There is a campaign and there is a people's involvement to make sure that the social distancing norms and wearing of masks and hand hygiene and other measures such as protecting the elderly and promoting the use of immune stimulating therapies from Ayush are being promoted in a very significant way. Lastly, I like to also state that India is a hub of science, hub of innovation, and hub of technologies. And in that regard, we have significant developments in the field of diagnostics. There are 30 companies indigenously who are now producing diagnostics. We have a capacity of more than 500,000 diagnostic tests indigenous per day already, and so much more to come. These are the companies which were not making anything. We were not making even a single PPE. Today we make 500,000 PPEs every day. Same with the N95 masks. But moving on, the repurposing of drugs has been done. Remdesivir has been given a voluntary license to 6 companies. Almost one, but maybe 2 companies are now in a position to even distribute the vials. We are looking at several other medicines in the research mode by our companies as well as by academia. But above all, I must also say that we are preparing ourselves for the final battle, which is having a vaccine or a set of vaccines. At least 6 to 8 companies of our country are already engaged with other and partnering with companies in the world, preparing for the vaccine. So at some stage, the vaccine trials would move to India. But whatever may be the origin of the vaccine, we believe that a large, if not 80% kind of a high volume of vaccine produced in India. It may come from any country, any group, but ultimately produced in India, for India and for the world. And our industry is rising to be prepared for that. And the government is facilitating every which way to make sure that our industry is ready, industry is supported, industry has a regulatory regimen which is efficient and which is very promotive. Also, lastly, at least 6 of our national laboratories and the scientists therein are working on vaccine molecules themselves. And we hope to give a push to those wonderful scientists of our own country. Some are totally indigenous. A couple of them are in partnership with collaboration with the global academic institutions. The fact remains that track is also very special for us. There is at least one totally Indian drug, which is the early phase of, it's a phyto botanical product, which is in trial. So I would say on the whole, a huge innovative and science effort is being mounted by this great nation. And we believe that in times to come, and even perhaps already in terms of the production of drug like remdesivir, India is not only going to serve the people of India, but also the people of the world. In a nutshell, one message that we have limited the disease as a nation to a level which is unique through systematic efforts and stellar leadership of the Prime Minister. 2, that we have mounted a huge preparation. And 3, our science response to the pandemic is building up and perhaps will be the most important player in that regard in times to come. Thank you very much.
Thank you very much, Dr. Paul. We know how busy you are. And Dr. Nandkumar, Dr. Shiv Sareen has joined us. So Professor Sareen, and over to Dr. Nandkumar.
Thank you, Anupam. Thank you, Dr. Paul. I will go quickly to introduce Dr. Sareen as we are really on a tight schedule this evening. And again, somebody who needs little introduction to many of us, but I'll still do my responsibility. Professor Sarin is Director, Institute of Liver and Biliary Sciences and founding chief editor of the prestigious journal Hepatology International. Professor Sarin has helped develop 17 major treatment guidelines, including spearheading 5 major Asia-Pacific treatment guidelines in liver disease. He leads the Medical Council of India as chairman of the Board of Governors, which position was in 2010-2011, and has been awarded the Padma Bhushan in 2007 for his overall seminal contribution to the medical field. Dr. Sarin, 10 minutes.
Thank you, Dr. Jairam, and thanks, Anupam. It so happens the first 3 are all liver people, that is Dr. Paul, Anupam, and myself, and it means it's a good day for us, and thank you to see everyone across the globe, and I'll take you to some of the thoughts on, I know many of you are aware of how to test, but I'll take you through, bring greetings from the Institute of Liver and Biliary Sciences, which is the only global deemed to be liver university. And I have no conflict, except most of the work is done by brilliant people. And you can see Dr. Ganguly here, who is also in the Apollo, but also advises us regularly. And with all humility, we are ranked for 3rd year in a row after AIMS Delhi as number 2 in the national ranking on scholastic and research outputs. I'll cover briefly the succinct point related to the diagnostic parts. Dr. Paul, who has so ably led the field, has covered most of it. So I'm just telling you what we can do more. So countries are testing, are they doing enough? According to WHO, when you test, then your positivity should be between 3 and 20%. And that when you see in India is okay, but India is very dense. Delhi is 20 to 25%. When you compare to any other country, we are still testing less. As you see the days from February to June 26th, other countries have started doing, let's say, 1 patient per, 100,000 or so. And India is doing still much less per 1,000. So we need to go much faster and higher. Now, India is doing symptomatic as well as asymptomatic, which are high risk as per ICMR guideline. We are much better where people are only doing with symptoms. So India is doing symptoms plus asymptomatic, but it's a huge country. Contact tracing, is India doing well? You can see US is doing limited tracing, while those where comprehensive tracing, India is in that league of nations. Yes, we are scaling up, but we have much more to do. Now, what are these lab tests about what we are talking? So this is an RNA virus. As you can see that there is a nucleocapsid, there is a genomic RNA, and it has several proteins, of which most popularly known as spike protein, the membrane protein, the envelope protein. Now these viral components, either the viral RNA, where you can do RT-PCR or several other techniques, or the viral proteins, which can be detected as an antigen by ELISA or chemiluminescence, or you can see the host response. These are the antibody-based tests. We have real-time PCRs, we have point-of-care cartridge-based or antigen-based, or you have serology-based. What we are using globally and also in India, and RT-PCR, which takes 2 to 4 hours, it is time-consuming. We also have started now the rapid antigen test, which takes 15 to 30 minutes. But I want to tell you it is very risky because your antigens are probably maybe different. And I'll briefly tell you because these are Korean or other countries' kits. Now, which sample to collect? We are generally collecting nasopharyngeal or oropharyngeal, which is on a swab, which has Dacron or polyester flocked swabs. Remember, these swabs have to be carefully transported and stored. If you look at the nasal swabs give you the lowest CT value. Lower the CT means control to test, lower the PCR runs, higher is the viral load. So you have a lower CT in the nasal swabs while you have a higher CT in others. Therefore, nasal swabs are good. Also, you can do bronchoalveolar lavage if there is an intubated. You can take sputum or saliva, and of course, nasal swabs. Now, these are some important slides. Now, the country and many parts of the world, US and others, are doing what are known as rapid antigen detection tests. I want to stress they are all very, very recent data. They are 5-fold less sensitive than RT-PCR. When you take RT-PCR, unless the values are very high viral load, they can be negative. So their sensitivity may be much lower, and therefore, if it is negative and you suspect, please go to RT-PCR. Secondly, you can see that the positive and negative, the log levels in the negative is much lower. Now comes to the antibodies and what are these. So one is the antigen detection, viral detection. Second are the antibodies. So everyone believes that IgG is protective, but the data is limited. Neutralizing antibodies, very few are testing for it, and specific kits are required. Mere presence of antibodies, let's say you start plasma therapy, antibodies, doesn't mean it is protective. What we are doing is a rapid diagnostic test takes 10 to 30 minutes. These are lateral flow tests. You also do enzyme linked or you do chemiluminescent assays. Why sero tests are required? You require them for prior exposure, for contact tracing, and in a way work permit. In fact, people are giving passports on that. Seroprevalence, as the ICMR and Dr. Paul's committees have recommended, will tell us disease trends. We do require community screening of asymptomatic, and I strongly believe India hasn't done enough on that. We have to have, let's say, July 1, August 1, September 1. Trends must be, we have to do tests before you give convalescent plasma. Every plasma is not good, and this will be helpful for trials. Remember, the virus becomes positive about 4 days before symptoms come. And this is the red line which shows, and then it peaks out. The IgM antibody will come by day 4 of the symptoms, and then it will start to fade down. And IgG, the test that you are doing, IgG test, here you can see, comes at about 7 to 10 days and it stays for longer. So there will be a period where IgM and IgG both are there, and they are helpful in our diagnosis. Now you see that neutralizing antibodies, nobody talks about them, but they're very, very important. These antibodies are protective. If you give them to rhesus monkeys, then you expose them, you do not get it. So it's not merely IgG, it is the neutralizing antibodies. Very few people get the titers of 1,000 or 2,000. And in the COVID-19, you can see the titers if they are higher in these patients. And very interestingly, people who are elderly, 40, 50 or 60, people say they are more likely to die. But remember, if they are mildly infected, they have the highest neutralizing antibodies. Next is which test to perform. The simple card test, the lateral flow, ELISA or chemiluminescent. Chemiluminescent is probably the best today, and both IgM and IgG have now become available. What have we learned from the seroprevalence study? And these are important slides. Just to tell you, this small study from Geneva of 5,000 people, what they showed in this study in week 1, week 2, week 3, week 4, week 5, the number of positives increased, but even then only 5% of the population was exposed during this pandemic. 95% still remains susceptible. And that's a huge challenge. India gets 1%, 10%, 5%, 90% may remain. Let's look at the antibody prevalence in Wuhan. About 17,000 people were tested, and between March to April, positivity was around 3.5%. Seropositivity was lower when you go away from the epicenters. Those who were visiting hospitals, like healthcare workers, those coming for dialysis, they had much higher antibody because of subclinical infection. In India, we have COVID Kavach, very good. ICMR is doing this, and NIV Pune approved it. Now, what I want to say is it is 92% sensitivity and 97, extremely good, but still we can miss 10% or so. The earlier survey, which ICMR, Dr. Bhargav, said 26,000, only 0.7% were seropositive. It is likely we are missing 30 to 100 times of the positive. In a way, it is good. They are not symptomatic, but we need to have larger surveys. I'll just take a minute or two to cover. This is the data in blood donors. Now, tomorrow you will have all these people coming as blood donors. So what should be our strategy? And those who got an infection for less than 10 days, they did not develop antibodies. But if the infection was for more than 10 days, they developed both IgM and IgG. We will require a national policy where IgG has to be tested and a duration of at least 4 weeks after infection is over has to be designed. So I'll summarize. This is my last slide. And I want to stress on some of the significance of the testings. A PCR positive, RT-PCR, is a patient who is either in the window period, even before infection, is symptomatic. So it's pre-symptomatic or in a way asymptomatic. Second, is the patient who is PCR positive and IgM positive, he is probably in the early stage of infection because IgM comes after 4 days. If the patient is also IgG positive and PCR positive, this is active infection. And this is what you see when a patient is in ICU. The PCR positivity stays for 3 to 4 weeks. Those who have liver disease, diabetes, hypertension, in them, this stage is the one which causes death. And here you read antivirals as well as other anti-inflammatory agents. I think all ICU patients must have PCR, IgM, and IgG test. Patients in the late or recurrent stage of infection have IgG and PCR. IgM has gone, but IgG is there. Another group is only IgM positive. This may be early stage, PCR may be false negative. So patients who are sick, symptomatic, if they are negative for their PCR, you should do an IgM. And IgG may have had a past infection in the patient and has recovered. This is good for us. And IgM and IgG patient may be in the recovery, or PCR is false negative. I have not shown you neutralizing antibodies, which I think an ILBS does about 500 of these antibody tests, not to give any praise, and about 800 to 1,000 PCR tests. And we have a huge data to say that this particular test scenario is very useful for us to imply in our clinical practice as well as serosurveillance, seroprevalence studies in the country. Thank you for your attention.
Thank you so much, Professor Sareen. Thank you so much, Dr. Nandkumar Jairam. And I'm now going to invite Dr. Gautam Bodhibala, who's one of the most well-known experts in emergency medicine globally. In fact, the department in Leicester is known as the Gautam Bodhibala Emergency Department. The most valued award by the International Federation for Emergency Medicine is called the Gautam Bodhibala Lifetime Achievement Award. He's a member of the Court of the University of Leicester, founder member of GAPIO and a member of the Executive Committee of GAPIO, and has been honored with the Commander of the British Empire by Her Majesty, the CBE. Over to Dr. Gautam for introducing Dr. Guleria and Dr. Ganguly. We are going to be pushed for time because the next session in the US is going to take off. So really requesting everyone to stick to time. Over to you, Gautam bhai.
Thank you very much, Anupam. Thank you for your very kind introduction and congratulations for picking up such wonderful speakers for our session. And the bad news falls upon me that at 1:55, the pool is going to they're going to pull the plug as far as our session is concerned. So I would very much request our next two speakers to stick to the time. If I'm short on introduction, I ask their forgiveness. My first speaker is Professor Randeep Guleria. Most appropriate as far as the session is concerned, because Professor Guleria is part of the core team of the top Indian officials monitoring pandemic in India and is involved in building the strategies as far as the management of COVID-19 is concerned. He's a very reputed pulmonologist and the director of AAPI in New Delhi. Professor Guleria is conferred with a prestigious Padma Shri Award in 2015 by President of India. I invite Professor Guleria to give his presentation. Thank you very much.
Thank you very much for having me over. I'm just trying to share my screen and see if I can do that. Otherwise, I will just be, I'm not able to go into my own laptop.
You have the ability to share, Randeep, so give it a go.
Okay.
Great, we can see you if you just want.
Can you
Yeah.
see the screen now?
Yeah, we can see you now. We can see the presentation. Thanks.
Thank you very much. And I shall be focusing predominantly on India as far as clinical care is concerned and how we've managed to look at the management of COVID as far as India is concerned. As has already been said, that we are facing with a dangerous virus which has an ability to spread very rapidly and lead to multi-organ involvement along with cytokine storm. Again, we have a huge profile as far as patients are concerned, and that's why clinical care becomes challenging, because we have a large number of asymptomatic patients, we have pre-symptomatic patients, then we have individuals with mild illness, moderate illness, severe illness with severe pneumonia with classical features that we are now learning as far as the CT or the X-ray is concerned, then with very complicated cases with acute respiratory distress syndrome and sepsis, and we are now seeing a large number of individuals who have atypical presentations. We've had a whole number of individuals presenting to us with young strokes because of the hypercoagulable state that COVID is now known to cause. So it becomes a challenge as far as clinical care is concerned, as far as managing these patients are concerned. This has already been mentioned by Professor Sareen, that you go through various periods, including an incubation period, symptoms, and a resolution phase, and that tends to vary. The government of India has come out with the clinical management protocol, which was upgraded yesterday only based on a discussion that the National Task Force had on Friday and the Joint Monitoring Group had yesterday. And I shall focus a little bit on this also. But when we start looking at spectrum of COVID-19 cases, you can have mild uncomplicated cases where this is the bulk that we tend to see. You can have mild pneumonia, and we have a number of our patients who actually seem to be doing very well, but they have patches on the CT or the X-ray and require only oxygen therapy and tend to recover pretty in a few days' time. But we then have patients with severe pneumonia which require ventilatory support, and then we have a number of individuals with complicated illness. Now, if you look at the strategy that India adopted, and this strategy was one of the outcomes of the lockdown because it gave us time to prepare, we rapidly realized that we were having a large number of patients who actually had mild illness and did not have what we were initially very worried that there would be a large number of patients requiring ventilatory support. The strategy changed from looking at developing good COVID care centers and centers where good oxygen supply and supported treatment were available, because the number of patients requiring ventilator support was not as high as we had initially anticipated. As a matter of fact, we have a large number of patients who are COVID positive admitted in our hospital. At one point in time, we had more than 700 patients admitted. Now the number varies around 500 to 550 per day. But the number of patients on ventilator continues to be on an average around 40 to 50. We haven't really had more than 50 patients requiring ventilatory support. So a large number of our patients are requiring oxygenation, prone position, HFNC or NIV, and many of them have comorbidities, which makes the disease a challenging thing to monitor. And that is why a large number of patients who have mild illness, we tend to send them to the COVID care centers. Then we have a group which has moderate illness, which is pneumonia with no signs of severe disease. And these are those who are being managed now in dedicated COVID healthcare centers where you have oxygen support and where you can provide care to these individuals in terms of supportive care. And in some of these centers, there is provision for non-invasive ventilation also. You do have some individuals who will continue to have severe illness. This is a complicated illness. So there is a need there to have dedicated COVID hospitals. And as these hospitals come up in parts of India, in various districts, it became essential to really develop a mechanism to be able to mentor these institutes, and a facility of EICUs and mentoring of the doctors in district hospitals was also set up. AIMS itself has set up a facility known as Connect, where we try and connect to doctors across the country who are managing COVID patients, and critical care specialists, pulmonologists, and ID specialists talk to them in terms of helping them manage sick patients with COVID-19. There are issues that we need to understand in any pandemic. The first issue that we have in a pandemic is in a triage area. And then when do we decide on domestic care, critical cares, and how do we manage the hospital surge capacity, which is happening in many parts of the country. We've seen that in Mumbai, and we've also seen that to some extent as far as Delhi is concerned. So whenever you have a pandemic, there is increased apprehension, there's increased consultation for respiratory tract infections, and those patients who could otherwise be managed at home sometimes rush and want to come into the hospital, and even mild care require only home isolation. And sometimes because of just the panic reaction, we are overwhelmed with patients coming. In our employee EHS facility, where we are doing testing for all our employees who have even mild symptoms, about 3 weeks ago, when there was this huge surge, it led to a huge panic, and we had almost 400 to 500 people from the staff coming to get tested because everyone was worried that they may have contracted the infection. So there does have a panic reaction leads to an increasing demand as far as the healthcare system is concerned. And based on this, the government of India almost 2 months ago went on to develop the strategy of having dedicated COVID hospitals, COVID ICUs, a screening area which was known as a COVID suspect area, where you could keep patients who had symptoms but were waiting their tests, and then an ILI facility and a COVID care center, which could be more in a community center. There was also a plan to identify such centers which could be upgraded, and over the last 2 months, many hospitals have been converted into COVID care hospitals, and many areas have come up as COVID care centers. A triage flow chart was also made where you could decide on how to really stratify your patients based on those who presented with classical ILI, having symptoms which suggested that they could have COVID-19, and then an evaluation depending upon various categories as to the severity of illness and decision whether they needed to go to a COVID care center, a COVID hospital, or a COVID ICU. In the COVID care center or in the COVID hospital, there had to be close monitoring so that these patients, if any of them deteriorated, they could be shifted to a higher facility. So in hospital care, depended on the patient's current condition, complications of COVID-19, if there was any worsening of pre-existing condition, if the patient was in a higher risk group, and various tools like the Curve 65, clinical and radiological evidence were all used in terms of deciding whether this patient required hospital care or not. Currently, a large number of our patients were able to manage, and this has taken some time to convince some patients that they do not require hospital admissions, and therefore home isolation, if facilities exist, has become more and more popular. Home isolation can also be done in hospitals. This was what we did in the beginning when there were less number of cases, but then we have now moved on to encouraging people who have the facility to really stay at home or look at what is known as non-traditional setting, which could be stadiums, auditoriums, or a paid facility like hotels also. There are counsel about the signs and symptoms of the complication, and they are told about the warning signs which they need to watch out for and for which they need to come immediately. The government has now even decided to provide pulse oximeters to these people who are at home isolation to monitor the saturation, respiratory rate. But if they have trouble breathing, persistent pain or pressure in the chest, or there is new confusion or inability to arouse or bluish lips or face, then they are asked to immediately report to the health facility. So home management has now become more and more popular, and that has actually to some extent decreased the load on hospitals as far as home care is concerned. The government of India also came out with these guidelines, which are there on the net, which are looking at home isolation for mild or pre-symptomatic COVID patients. And this is in a way to decrease the load as far as hospitals are concerned, but not compromise on the quality of care as far as these patients are concerned.
Professor Guleri, your time is up now, please. Thank you.
Yeah, so I'll just quickly finish. I think, go to the last two slides. I'll just finish with this, and I'll just say that what we are planning to do. So there is a lot of change that has occurred in the ventilatory strategies. I just wanted to briefly discuss on that, but that I think I'll omit. There has been a large number of drugs as far as clinical care has been looked at, and this is a group which looked at various drugs which are available in the Indian, which have potential, and try to rate them as far as drug potential for India is concerned in terms of availability, in terms of cost. And this includes hydroxychloroquine, favipiravir, leponavir, and ritonavir, and remdesivir. And a large number of other drugs like ivermectin have also been tried, and they may also have a potential. Final slide, which actually tends to show the guidelines in a more comprehensive manner. This is the latest Government of India guidelines, which look at mild cases, moderate and severe cases based on risk stratification of respiratory rate and the saturation. And those who have more severe illness, steroids are also recommended. And we've also added dexamethasone along with methylprednisolone, which we're already giving in the past, but based on recent data, that has also been added. And remdesivir, convalescent plasma, tocilizumab have all been looked at as investigational therapies. So this is to give you a broad overview of the current scenario as far as the clinical care of COVID-19 is concerned. So I think I've tried to stick to my time. Thank you very much. Just one.
Thank you very much. I do apologize for a very unkind interruption, but we are going to finish very soon, and I wanted to give some time to Professor Ganguly, who is our next speaker.
Okay.
I'm not going to do justice as far as his CV is concerned. Professor Ganguly has got a very rich CV. And if I were to tell you everything, probably I'll take the whole session mentioning
you
about
can
him.
skip my CV, Dr. Bodiwala, so that I can speak.
Okay. You're very kind. I present to you Padma Bhushan Professor Ganguly. Thank you very much.
Okay. Thank you, Dr. Sebbal, and thank you, AAPI and everyone for this opportunity. As Dr. Sebbal says that there is every few minutes and a research paper is coming out, and every other day the whole concepts are going head over heels and being changed. The problem is that many of them are not peer reviewed, and they are being put in the public domain, and one has to really spend 2 to 3 hours going in depth with them to really find out that whether these are, how much do you take and what inferences you make, and there need to be a think tank which need to do it continuously. The research is very necessary for the outbreaks, pandemics, as well as the disease control. India has, without research, it can't be done. In 2 areas, India has done well. In the cases of AIDS and in case of polio, where research has guided the containment and the control. I will just take one example how research has guided. For the polio, the AAPI surveillance, the viral molecular surveillance, which we did almost for the world and tracked it around the globe, caught the shrinking of the genotypes and created every intervention in India and globally based on that. Then we came to the environmental surveillance, which was very powerful for COVID also. Now we have seen that environmental surveillance will be very, very important. We also went to the bivalent intervention, which was also very, very useful, and which showed the globe that what we can do. And then we introduced IPV in our country, as well as we were now thinking of, because it is again coming up, the vaccine-derived viruses, the new polio vaccine. The same principle will actually prevail for the COVID also. So what we need to do is set up a world-class surveillance, which will provide constant data and feedback to the controllers or the researchers and scientists to come up with the better intervention. And this has to be done, as we have seen for the AIDS. We have to free the surveillance for the CDC India, ICMR, and other organizations, as well as for the other scientific organizations like ILBS or any other organization which wants to go into surveillance, because that in the AIDS that was very, very rich and useful. So then we come to some science which actually describes this virus. This virus, in about 7 or 8,000 of this virus has been completely sequenced. And this virus is little bit unique because this virus, in India only 2 clades are there, but there are 10 clades which are circulating around the world. There is a thinking, but not a firm thinking, that this particular virus may have such signatures which cause severe asymptomatic or symptomatic disease. But that one very important feature of this virus is this, that it anchors not only ACE2 receptor, but with clathrin and with integrin, and which enters, it not only prevents phagosome-lysosome fusion, it is a very basic charged virus, which is not, other viruses are not that. So it creates a huge metabolic disturbance and an inflammatory disturbance in this. From the bats, what we have learned, that these bats have higher temperature, and so this virus, when temperature normally controls the virus. So when in humans temperature rises, the COVID virus survives over there. The bats have a good immune system, but they don't have the inflammatory switch. The humans have inflammatory switch, and inflammation comes because of that. The nocturnal habit of bat and the human, which is not there, also helps us to survive in human. So these bats are, although it's not firm that they are the spreader for this, but we know that they spread Ebola, we know that they spread Nipah, we know that civet cats spread the SARS-1, and the monkeys spread the AIDS. But here, the human-to-human transmission had happened because it may have jumped to pangolin and then to human. Now it is human to human, and that is worrisome. There are 2 definitions for human to human. One, it starts from one human to human, circumventing the animals, or when about 70% of person know that they have not been exposed to, from where they have been exposed to virus. The other thing which I want to emphasize is this, that if you study America, and if we study chikungunya, dengue, and other infections in India, at the moment it is in the metros because most people came there, but it travels to other part of the country. So nowhere we are safe. So what we need to do, strengthen our secondary health systems as well as the village health systems and others. It is going to travel, and it is going to take its course, as it was said by Dr. Sareen, that about a large population is not immune, and herd immunity is not there. In New York, only 25% have developed herd immunity. 60 to 70% is needed to prevent the transmission. So this is something which we need to strengthen. Health system need to be strengthened. There are 3 organizations in India which have strengthened the health system. One is Dr. Sareen's place, where everything is going on, although they are taking COVID. The second one is the Tata Memorial Center. They are, because cancer patients are dying. If we have to do health systems in a way that other diseases are also taken care of. So that is again something has happened there, and we need to study, and we need to do that. Our all specialty hospitals work on that. So health system research is a very important part. Apollo has also done that, and Apollo has been a very successful model in the private sector, and one should study that. Finally, I come to 1 or 2 more points before I finish, because I know the time is very tight. There is a vulnerability list by the CDC very recently. I will add on to that when attending Dr. Sareen's classes, The liver diseases, the fatty liver diseases and obesity related liver diseases are also very, very vulnerable. Finally, our inflammation is different than the Western inflammation. This vascular inflammation, as has been taught and it is now studied and proven, vascular inflammation in India is lesser than the West. In the temperate countries and colder countries, vascular inflammation, which is a very important part of this, is much more than what is in tropical countries. So that is one of the saving grace in our place, and that is why the newer methodologies to handle inflammation is very, very important, as well as the complement activation. There's an elegant study in Dr. Sarin's place where you could see that the complement fragments sitting on the surface of the blood vessels. I wrap up my, because you cannot really present all the research which has been done, I wrap up my thing by saying that we need to really do all these tests which were listed. We were doing it already all around India. The point of care tests, the antigen tests, antibody tests, RT-PCR, the PCR test, LAMP, we were already doing all over India. We need to really use quality thing. There is a list for the quality things, but we need to cover all over India with the tests. We need to ramp up tests. CDC said that the 24% lesser numbers are being detected. Dr. Sarins also said much higher than which are going undetected. So this is something which will ultimately give us a proper thing. And if we do proper modeling, as Chris Murray and others are doing, and mask is the only preventive thing at this given moment, an appropriate proper mask, which reduces 35,000 deaths in the United States if it has been used. Thank you for this opportunity.
Thank you very much, Professor Ganguly. You couldn't have a better person to wind up this session, who was the former Director General of Indian Council of Medical Research and who has with him experience of publishing 775 research papers and supervised 130 PhD theses. I hand back to
Thank you so much, Dr. Bhai. Thank you, Dr. Ganguly. Thank you, Dr. Guleria. Dr. Sudhir Parekh and Dr. Ramesh Mehta, we are not going to be able to take the Q&As. We'll pass these questions on to the speakers. Of course, lots of suggestions which we will pass on. But I just wanted Dr. Sudhir to give his closing comments in 30 seconds. Sudhir Bhai is a distinguished allergy immunologist, Padam Shri, Alice Island Award winner, numerous honors. He's the Secretary General of GAPIO and past President of GAPIO and currently the President of GAPIO. Over to Sudhir Bhai for 30 seconds and then Ramesh Bhai for 30 seconds and then we'll have to close because there's another application in precisely 20 seconds.
Well, thank you, Anupam. Dear friends, this is an excellent 1 hour learning experience. And I got several comments and everyone is so happy and see the what a comprehensive presentation we have done. And I must congratulate all our panelists, Dr. Ganguly, Dr. Saran, Dr. Gurera, and Dr. Paul. So thank you everyone. And I think we did a great job. Thank you.
Over to Ramesh Bhai. Thank you, Sudhir Bhai.
Thank you. Hi from sunny London. Beautiful presentations, lot of learning. I know there have been lots of questions, and as Anupam said, we will try and get the answers from the speakers. So it has been really enjoyable. Thank you, everybody. Great speakers. Thank you.
Thank you so much. A big thank you to Dr. Suresh Reddy and his AAPI team, to Dr. Sudhakar, to Anupama, to Bhavna, to Vijaya, the executive committee of GAPIO, esteemed speakers and moderators for bringing us together. Just wanted to let everyone know on the 12th, we have a very clinical session where we get into remdesivir, plasma, favipiravir, steroids in depth. And then on the 23rd of of July, His Holiness the Dalai Lama will be doing a session with us. So we look forward to seeing you on the 12th and then on the 23rd. Thank you ever so much, and over to AAPI.